And I want to pause here and say, like, I think that helps with the collaborative nature of how we all behave. And I know that you guys do it in San Diego as well. The collaborative nature, like, it's very easy for me to say, hey, I've hit this thing with Y90 twice, and it's just progressing outside of my treatment zone. And I can keep chasing this, and I know that I can keep treating it, but I'm losing the race right now. And so what makes the most sense in terms of taking care of this patient? And then it's having a quick interaction with y'all. Hey, guys, treated it twice or treated it once, and it looks like it's progressing pretty quickly. What do you think about immunotherapy here? And, especially in somebody that has preserved liver function, I mean, throw more at it. I like the concept of it. If they're not going down the transplant route, it makes a lot of sense to combine.
It's somewhat of a culture change, though, right? Like,
yes.
Traditionally, it's all local regional therapy is possible, and then you're done with local regional therapy, never to get local regional therapy again. They go into systemic, and then, at least in my clinic, just lost forever, right?
Right. And medium overall survival of 10 months with sorafenib.
Yeah, right? And so that's kind of how it was, right? And so it's a culture change a little bit, even from, at a tumor board level, like when you have a discussion, right? It's we're no longer just doing local regional therapy until they either can't tolerate it or have had too much progression, right?
Mm-hmm.
I don't know what the right answer is. We're all kind of trying to figure it out as we go until we have better data, but it's definitely changing pretty quickly.
I do think all of these studies are very important, though. At the risk of busting the chops of my IR colleagues, you guys have a lot of tools in your toolkit. And instead of just doing these things and seeing what happens, I think it's important that we study these things in a prospective way, because yes, the scenario that you outlined of my Y90, we did it twice, we look like they're progressing, we need to move systemic therapy. That's a pretty easy conversation for us to have. But if you look at these other studies where you're prospectively committing someone to a combinatorial approach of either TACE plus systemic therapy or TARE plus systemic therapy, those people are going to be on systemic therapy for a long time.
Right.
And we want to make sure that they're actually deriving an efficacy benefit, and that, particularly for LEAP-12, I mean, that's using lenvatinib for a prolonged amount of time, which has a lot of toxicity. So we want to make sure we're really doing what's best for the patient in terms of improving an outcome, not just doing something to make ourselves feel better.
100%. I totally great consideration there.
Yeah, that's why I think 100% agree with you. And I think what Zach was saying earlier is that, yes, these are positive studies right now because PFS, progression-free survival, is shown to be beneficial. But if these are not improving overall survival, I would say these are negative studies, right? I mean, that's what we care about. We're not making their lives any better by putting them on lenvatinib every day. Immunotherapy, most people tolerate fine, but it doesn't make you feel any better unless we're treating your cancer better. But what we care about is survival, overall survival in those patients. So, I think the jury's definitely still out. If we're not moving that needle, then I would say we're this will be a not the right approach.